Assalamu alaikum and a very good day to everyone. Today we are going to look at genetic and acquired abnormalities of the bone. We are going to describe the pathophysiology and morphology of rickets and osteomalacia. We are going to see the effects of hyperparathyroidism on bone, describe the morphology and clinical features of Paget's disease of the bone, and then we're going to look at pathogenesis and clinical features of osteogenesis imperfecta, achondroplasia, and osteopetrosis. These diseases are either acquired or inherited. Now, all of these diseases leads to weak bone conditions, and they can cause deformities and fractures. Note that osteoporosis is not covered in this lecture as it is covered in PBL. To understand some of these conditions, it is important to know the physiology of hormones in calcium and phosphate homeostasis. The net effect of vitamin D is to increase calcium and phosphate level. What vitamin D does is, it promotes calcium and phosphorus absorption in the intestine, promotes reabsorption of calcium in the kidneys, promotes bone formation and mineralization, and inhibits parathyroid hormone secretion from the parathyroid gland. Another important hormone is the parathyroid hormone. The net effect is to increase calcium level, but to reduce phosphate level. Parathyroid hormone promotes bone resorption by osteoclasts, which increases calcium level in the blood. It also enhances active reabsorption of calcium from distal tubules. It enhances the absorption of calcium in the intestine by increasing the production of activated vitamin D, and it reduces the uptake of phosphate from proximal tubule of the kidney, thus losing phosphate. Bone is made in two stages. Collagen matrix or osteoid is formed first by osteoblasts. 2 weeks later, it begins to undergo bone mineralization or hydroxyapatite crystals. The osteoid is like the brick layer in a house wall, and the minerals are like the cement that strengthens the wall. Mineralization of osteoid can take place only if there are sufficient calcium and phosphate ions. Both calcium and phosphate levels has to be normal to have normal mineralization. If the blood level of either calcium or phosphate is low, mineralization is impaired. Inadequate mineralization of osteoid is called rickets in children and osteomalacia in adults. The most common cause of these diseases is vitamin D deficiency. Under normal physiologic conditions, calcitriol is synthesized via a series of steps. First, ultraviolet light converts 7-dehydrocholesterol to pre-vitamin D3, which is then converted to vitamin D3 or cholecalciferol. Relatively minimal sun exposure is needed to synthesize cholecalciferol in the skin. 10 to 15 minutes of exposure provides more vitamin D3 than any known dietary source. In the absence of sun exposure, cholecalciferol can also be obtained naturally from the diet from foods that are fortified with vitamin D or from vitamin D supplements. Vitamin D binding protein carries vitamin D2 and D3 to the liver, which converts them to 25-hydroxyvitamin D or calcidiol. The enzyme 1-alpha hydroxylase, which is expressed primarily in proximal tubule of the kidney, then converts 25-hydroxyvitamin D to 1,25-dihydroxyvitamin D or calcitriol, the biologically active form of the molecule. Parathyroid hormone stimulates 1-alpha hydroxylase activity, whereas phosphate and fibroblast growth factor inhibit activity. Vitamin D promotes calcium and phosphorus absorption in the intestines, promotes reabsorption of calcium in the kidneys, and also promotes bone formation and mineralization. For optimal metabolism of vitamin D, two conditions must be met. There must be enough vitamin D in the body, and the vitamin D must be converted to the metabolically active form, which is calcitriol. When there is vitamin D deficiency, there is inadequate substrate for the renal hydroxylase. So this leads to lack of 125 hydroxy vitamin D. Absorption of calcium and phosphorus from the gut is reduced. The serum levels of calcium and phosphate will drop, and hypocalcemia activates the parathyroid glands. The parathyroid hormone will cause mobilization of calcium and phosphate from the bone, and also causes wasting of phosphate in the urine and calcium retention. This serum calcium are normal or nearly normal, but the phosphate is low, so mineralization is going to be impaired. Predisposing conditions for rickets or osteomalacia includes impaired metabolism of vitamin D, phosphate, or calcium. This can be due to inadequate synthesis or dietary deficiency of vitamin D, decreased absorption of fat-soluble vitamin D, derangements in vitamin D metabolism, and phosphate depletion. Inadequate synthesis or dietary deficiency of vitamin D can be caused by inadequate sunlight exposure. This causes a deficiency in cutaneously synthesized vitamin D. Adults in nursing homes or healthcare institutions are at a particularly high risk. This also could be caused by limited dietary intake or dark skin pigmentation. People who have undergone resection of the small intestine are at risk for vitamin D malabsorption problems. Diseases associated with vitamin D malabsorption includes celiac sprue, short bowel syndrome, and cystic fibrosis. Some medications are associated with vitamin D deficiency. Drugs like dilantin, phenobarbital, and rifampicin can induce hepatic P450 enzymes to accelerate the catabolism of vitamin D. Renal failure is the most common cause of vitamin D deficiency. It causes decrease in 1-alpha hydroxylation of vitamin D due to the loss of the proximal tubule cells that synthesize 1-alpha hydroxylase. Diffuse liver disease decreases the synthesis of 25-hydroxy vitamin D in the CYP450 system. Phosphate deficiency can also cause osteomalacia, and that can be due to poor absorption of phosphate due to chronic use of antacids. Excess renal tubule excretion of phosphate can also cause this, such seen in X-linked hypophosphatemic rickets. When there is inadequate vitamin D, calcium, or phosphate, there will be inadequate mineralization. The osteoblast will still produce osteoid, but there will not be enough minerals to be pushed in the osteoid. In children, because the growth plates haven't closed yet, this leads to softening of the bones, impaired growth, and bone malformations. Note that the picture shows lack of mineralization and of the osteoid, which led to the weakening or softening of the bone. In children, the malformations can be seen as frontal bossing, prominent frontal bone of the head, and bowing of the legs, especially when the child begins to stand. Other malformations that can be seen are rachitic rosary, which is overgrowth of the cartilage or osteoid at the costochondral junction, and Harrison sulcus, which is the inward pull at the margin of the diaphragm. In adults, there will be excess of unmineralized osteoid bone, which leads to weak bones, and the bones are vulnerable to fractures. Fractures are seen especially at weight-bearing areas, such as vertebral bodies and femoral necks. The lab tests that are done for rickets and osteomalacia are vitamin D levels, blood calcium, and alkaline phosphatase. Bone resorption by osteoclast is indirectly stimulated by parathyroid hormone. Recall the actions of parathyroid hormone. Excess parathyroid hormone will cause excessive bone resorption by increasing osteoclastic activity. The entire skeleton is affected, but cortical bone is more affected than the cancellous bone. The bone changes in secondary hyperparathyroidism is usually not as severe as primary hyperparathyroidism. The severe hyperparathyroid feature, which is osteitis fibrosa cystica, is rarely encountered due to patients getting their treatment early. This is the X-ray of the hands that shows subperiosteal resorption as shown by the arrow, especially at the medial aspect of the middle phalanges of index and middle finger. The excess parathyroid hormone causes increased number of active osteoclasts. Here you can see the osteoclast tunneling and dissecting into the center of the bone as shown at the arrow. This is called dissecting osteitis. Increased parathyroid hormone is associated with increased bone resorption and replacement of the bone with fibrous tissue. With numerous active osteoclasts, there will be a lot of dissecting osteitis. This will cause microfracture and bleeding, so there would be a lot of hemosiderin-laden macrophages. The extensive resorption will cause cystic lesions to appear. This lesion is called osteitis fibrosa cystica or von Recklinghausen disease. The X-ray shows this lesion with extensive osteolytic process at the distal femur with bone destruction and moth-eaten feature. In severe hyperparathyroidism, sometimes there is an expansile tumor-like proliferation of osteoclasts. This is called brown tumor. The brown color is derived from the hemorrhage and hemosiderin. The treatment for this is surgery and calcimimetics, drugs that mimic calcium circulating in the blood that tries to trick the parathyroid gland into releasing less parathyroid hormone. You can also treat them with bisphosphonates. Renal osteodystrophy is defined as skeletal changes seen in patients with chronic renal failure. What happens in chronic renal failure? Well, there is phosphate retention and hyperphosphatemia because there is failure to excrete phosphate. There is hypocalcemia as vitamin D levels fall. Recall that kidney is important in vitamin D metabolism, and with the fall in vitamin D levels, there is reduced intestinal absorption of calcium. So there is going to be hypocalcemia and hyperphosphatemia, which both will stimulate parathyroid hormone secretion. This will cause secondary hyperparathyroidism that will produce increased osteoclast activity. The changes that can be seen in renal osteodystrophy includes osteitis fibrosa cystica due to the hyperparathyroidism, osteomalacia due to the vitamin D deficiency and hypocalcemia, osteoporosis, and if it happens in children, they may get growth retardation. Now we go to Paget's disease of the bone. This is a disorder of the bone remodeling that results in thick, weak bone at risk of pathologic fracture. It is mainly an osteoclast dysfunction. It is also known as osteitis deformans. This disease has 3 stages. The first stage is osteolytic stage, where osteoclastic bone resorption up to 20 times more than normal occurs. Then the second stage is a mixed osteolytic osteoblastic stage, where it is a predominantly osteoblastic activity with bone formation. The result of this is collagen being deposited in haphazard way. The third and last stage is burnt out osteosclerotic stage. New bone formation exceeds bone resorption in this stage. This results in structurally disorganized and weaker bone. Eventually, all the cells becomes dormant or burnt out. Evidence suggests this disease is caused by genetic and environmental factors. Familial Paget disease shows autosomal dominant inheritance, and there is evidence that there is slow virus infection by paramyxovirus. Usually, This disease affects patients who are in their mid-adulthood or more than 40 years old, and men and women are affected equally. Paget's disease of the bone can affect either a single bone or the whole skeletal system. It most often affects the skull, lumbar vertebra, the pelvis, femur, tibia, humerus, and scapula, and grossly there is marked bony thickening. Classically, we can see a mosaic pattern of woven and lamella bone, which looks like a jigsaw puzzle. Under polarized light, we can see numerous woven bone deposition because there is no bone remodeling. This deposition is weak and prone to fracture. Early in the disease, patients typically do not have any symptoms. However, over time, the misshapen bone can impinge on nerves and causes pain. Patients have thickened bone and there may be enlargement of the head because of the bone overgrowth, sometimes causing a lion-type face called leontiasis. Deafness or visual disturbances can occur because of overgrowth of the bone compressing the nerves as the nerve pass in the auditory canal or optic canal. Although the bones are thick, they are brittle and prone to fractures. Weight bearing causes bowing of femurs and tibia, which may lead to secondary osteoarthritis. And patients with Paget's disease have an increased risk to develop osteosarcoma or fibrosarcoma of the bone. Pagetic bone is typically enlarged compared to normal on X-ray. Usually there can be elevated serum alkaline phosphatase, but the serum calcium and phosphorus levels are normal. This disease may be treated with bisphosphonate, which is a drug that causes osteoclasts to undergo apoptosis and inhibits osteoclastic bone resorption. Achondroplasia. What is it? It is an autosomal dominant condition in which there is impaired formation of the long bones. In achondroplasia, there is mutated fibroblast growth factor receptor gene 3 or FGFR3. In a normal person, this FGFR3 has a negative regulatory effect on both bone growth. Its activation inhibits cartilage proliferation. In achondroplasia, the mutated form of the receptor is constantly active, so there is constant inhibition of cartilage proliferation, which leads to severely shortened bones. Remember that the long bones undergoes endochondral ossification, and periosteal and intramembranous ossification is normal in achondroplasia. The characteristic features of achondroplasia are apparent at birth. Here we can see the shortening of the long bones with the widening of the epiphysis. In this picture, we can see the achondroplastic dwarfism, which is shown as short proximal extremities with normal trunk and enlarged head. Osteopetrosis or marble bone disease, also known as Albers-Schonberg disease, is a rare inherited disease that is caused by failure of osteoclasts to resorb bone. This results in progressive obliteration of the marrow cavity and dense but weak bone. There are two major clinical forms: autosomal dominant adult and autosomal recessive infantile. There is too much bone formation without resorption, so the bones may appear to be dense, but they are fragile and can fracture. The pathogenesis is there are mutations that interfere with acidification of osteoclast resorption pit. Acidification is required to dissolve the calcium hydroxyapatite. If there is a mutation in the gene that encode carbonic anhydrase enzyme, so there is going to be an absence of the carbonic anhydrase enzyme that prevents acidification, and osteoclast function is impaired. Clinically, Defective bone tends to replace bone marrow, which can cause bone marrow failure. This leads to pancytopenia, which causes infections, anemia, and bleeding. Extramedullary hematopoiesis will lead to hepatosplenomegaly, hypersplenism, and hemolysis. Cranial nerve problems can also occur that causes optic atrophy, deafness, and facial paralysis. Nasal stuffiness due to mastoid and paranasal sinus malformation can also occur. Compare this with Paget's disease. The treatment is hematopoietic stem cell transplantation. Osteoclasts are derived from hematopoietic precursor, and the normal donor stem cell can reverse the skeletal abnormality. In osteopetrosis, X-ray changes will show diffusely sclerotic and dense bone. The marrow spaces is abnormally filled with bone, replacing the hematopoietic elements. Osteogenesis imperfecta is a type 1 collagen disease that manifests as deficiency in production of type 1 collagen. Essentially, this is too little bone, resulting in extremely fragile skeleton. The bone is rich in type 1 collagen. Other structures that are rich in type 1 collagen are joints, eyes, ears, skin, and teeth, and all of these structures can be involved in osteogenesis imperfecta. There are 4 types of osteogenesis imperfecta: type 1, 2, 3, and 4. Type 1 and 4 are autosomal dominant, and type 2 is autosomal recessive. Type 2 usually leads to death, bones breaking in uterus or during birth. There would be multiple and recurrent fractures, deformed vertebrae, as well as deformed long bones. As seen in this picture, you can see a baby with multiple fractures. The characteristic blue sclera is caused by thin and transparent collagen fibers of the sclera that allow visualization of the underlying uvea. The picture on the left shows the bones are markedly deformed and there are numerous healed fractures. The picture of the mouth shows dentinogenesis imperfecta. This causes teeth to be discolored and translucent. Remember, the teeth is also rich in collagen type 1. The teeth becomes weaker and prone to break and loss.